I'm Dr. Nathaniel Chin, and you're listening to Dementia Matters, a podcast about Alzheimer's disease. Dementia Matters is a production of the Wisconsin Alzheimer's Disease Research Center. Our goal is to educate listeners on the latest news in Alzheimer's disease research and caregiver strategies. Thanks for joining us. Today I'm joined by Dr. Jonathan Baktari, CEO and Chief Medical Officer of E7 Health, a preventative health and wellness company based in Nevada. Before launching a series of private health ventures, Dr. Baktari treated patients as a triple board-certified physician specializing in internal medicine, pulmonary medicine, and critical care medicine. In 2021, E7 Health released a study on Do-Not-Resuscitate, or better known as Dnr Orders in the American healthcare system. Analyzing peer-reviewed data from the CDC, American Heart Association, and Harvard Medical School over the past 20 years, the study found that the presence of DNR orders is increasingly connected to elevated death rates, poor medical care, and other negative health outcomes. Today, I'm going to talk with Dr. Baktari about these results in the context of Alzheimer's disease and dementia. Dr. Baktari, welcome to Dementia Matters.
Thank you so much for having me. What an honor. Thank you.
You launched E7 Health in 2009, and before then you were a physician seeing patients, leading in administrative roles and teaching medical students. How did your experiences throughout your career bring you to where you are today?
Well, it was a classic story of one door opening up another door, just always trying to get involved in more things, both administratively, from quality control, from patient advocacy, and just appeared that as I progressed in my career, one door, you go through one door and then something else opens up. And it was just a series of events that led me here, so to speak.
Was DNR something of particular interest to you because of your clinical experience?
Yeah, rounding on 10, 20 ICU patients every day for many, many years. Obviously, it was, a combination of DNR, and we could talk about withdrawing life support and palliative care, which have some overlap but are somewhat different. It became really important, not only as a tool to prevent suffering, but also honoring people's wishes in the right cases. And throughout that experience, I did see, a variation of how DNR was applied, how often it was applied. And part of that was the patient population and, and just talking to my colleagues across the country, in certain parts of the country, institutional biases in terms of how to approach it, how often to use it. And so when I talked to my colleagues across the country, there was a considerable discrepancy, which was pretty noticeable.
And we're going to get into that too. But to set the stage for our listeners, I want to ask some general questions for you.
Sure.
What does DNR actually mean, and when is it used in healthcare?
Right. So DNR, what it really means, of course, stands for Do Not Resuscitate. And I think it has really three components. Do not resuscitate applies to initially, for example, if your heart stops, in which case we would do CPR, a combination of CPR, what we call ACLS protocol, and potentially shock. Those three things happen essentially when your heart stops. So those have potential side effects as benefits potentially, and so people need to understand what CPR involves, what it means, the risk of CPR, the risk of ACLS, giving epinephrine and what have you, and following the ACLS protocol and other drugs, as well as, shocking the heart if certain rhythms call for it. So people need to understand what that is. That's one thing. The next thing is really intubation, which is putting an airway into someone's throat to breathe for them, and the pros and cons of having that done and the benefits in certain situations. And then lastly, to using vasopressors, which is epinephrine or norepi, levophed, all those medications that we give through a vein that often require a central line, what have you. So classically, those are the things that fall under DNR, and theoretically people can pick and choose out of those. Some people say, well, I don't want CPR and ACLS and shock, and I don't want to be intubated, but I wouldn't mind having pressors. So there are combinations of that. So that's CPR, which is really different than withdrawing life support, and which is slightly different than palliative care. And when DNR is applied, so I think it really broadly falls into two categories. Certain people choose DNR even when they're healthy. I've seen 30-year-olds and 40 and 50-year-olds, just say, hey, I do not want these heroics in case I'm in a tough situation where there's very little hope. And then lastly, you see it when patients come to the hospital and something catastrophic has happened, and then the discussion is made with the patient, or sometimes, for example, with dementia patients or patients who are just incapacitated, we have that discussion with significant others. So I think broadly speaking, although there's a middle road too, there are people who just don't want it, but there are other people who don't want it once they get diagnosed with something. And so it's not always the same how you see a DNR status come to being.
And a DNR order can always change, isn't that right, over time? Someone could reverse a DNR decision.
Right. You can withdraw the decision anytime. I mean, in certain states, there's this thing called DNR suspension. So you can suspend DNR while you're having surgery, theoretically, in the pre- and post-operative period. But yes, by and large, you can revoke it and you can restate it anytime you want.
And of course, then as a critical care doctor, can you have a DNR order while being in the ICU?
Oh, clearly. Yeah. I mean, because remember, DNR in the most traditional sense is do not resuscitate me, essentially, if my heart or lung stops. But you can get all sorts of care in the ICU which don't involve CPR or intubation.
I'm glad you answered it that way too, because I'm trying to make the point, though, in order for a DNR order to be acted upon, you actually have to die, right? Your heart has to stop beating and you have to stop breathing.
Right. And I think we're probably leading up to the rub where that's not often how it's interpreted. But in the most classic sense, yes, that would only apply if your heart and lungs stop, which is different than palliative care where you direct, I don't want any kind of care or certain kind of care.
Okay. So despite what you've explained to us, having this DNR order is not really as straightforward as your explanation. And so there's evidence that hospitals administer fewer blood tests, IV and routine procedures in individuals with DNR orders, which is not really a part of the order itself. So you and the E7 Health team did a study analyzing DNR orders in U.S. healthcare. What exactly did you find in this study?
Well, I can probably break it up into two kind of, I don't want to say shocking, but very cause for concern. One was simply the attitudes of healthcare workers. And this is such an easy test to do. You could do it at University of Wisconsin tomorrow, where you just take 100 nurses or 100 doctors, give them a clinical situation where a patient presents with something, and just mention on one, A and B version of the same scenario. In the B version, mention, by the way, the patient was DNR, and then list the whole series of things would they offer the patient: a blood transfusion, a surgical consult. So this is not something that is very hidden. Anyone can figure this out pretty quickly, that the medical staff, including residents, attendings, and nurses, view DNR, not all of them, but there's a statistically significant that they view DNR as some level of do not offer treatment or do not intervene in other things that have nothing to do with the DNR status. So that's simply, I think you can't get away from that. That's true in Wisconsin. It's probably true in New York and Florida and what have you. So there is how we got here is a more interesting discussion, but clearly the staff, appears that there's a tendency for them not to offer things. Or even, like if you're rounding on a patient and you're a subspecialist, you say, oh, well, that person's DNR, I'll only round on him 3 times a week. So there's even subtle things. It's not even just, or if you have a busy day, who are you not going to round on? And again, I'm talking about like as consultants, and so you're the surgery consultant on a DNR patient who's following up on something. So I think it takes many shapes and forms. So that's number one. Number two is actually looking at mortality, and some of these studies are pretty clear that there is when everything else is factored in, that DNR patients sometimes have a higher mortality for elective procedures, for emergency surgeries. And even just coming into the hospital for certain illnesses. So I think, when you factor in, their health of DNR and non-DNR patients and age and all those other things, there still appears to be a discrepancy. And honestly, we stopped after, 8, 9, 10 studies, but we could have gone, the literature is just so full of it. It's actually, I think the issue is every study looks at stroke patients, and another looks at elective surgeries. But if someone took all of those studies and put them together, the pattern is indisputable.
And so I know your study didn't look specifically at people living with mild cognitive impairment or dementia, but how do you feel like these findings impact these individuals or people who have progressive conditions?
Well, are you talking about these people with cognitive dysfunctions in terms of their ability to make the decision, or what happens to them after they make the decision?
Actually, I'd like you to answer both of those questions.
Right. So I think obviously the ability to make the decision, it will be hampered, because the solution we're coming up with is to be upfront and say, if you become DNR and you have elective surgery or emergency surgery, you may not do as well if you're DNR. So factor that into your decision. And I think the ability for people to factor that into their decision obviously would be hampered by their ability to fully comprehend what that means. So then you'd be talking about, maybe potentially talking to their family, which, at the end of the day, the more satellite view question is, does this mean we should get rid of DNR? And obviously DNR helps so many people that's not the answer. The answer is to address the small subgroup of people who this impacts negatively. Although, if you really look at DNR, if DNR was a drug or a medical procedure, it would be taken off the market. Because if 10% of people who got the COVID vaccine died, the fact that it helps 90% of people is almost immaterial. All right. If I came up with a new, migraine medication that killed 2% of the people it took, I couldn't make the argument, but it's helping 98% of people. So if it was simply a drug or a procedure and needed FDA approval, it would probably be taken off the market. I mean, we have a different bar for DNR than we do for other stuff. But in all fairness, because it does really alleviate so much suffering, because, in the 90 whatever percent that it helps, I couldn't imagine those patients not having it. And imagine the amount of pain and suffering we would cause in the end of life, or let's say, so it's really it's almost a philosophical issue, because I don't think anyone can dispute that there's a subset of patients that are getting hurt by this. But I think, those of us who've been in the trenches and have practiced clinical medicine for 20 years can't imagine, going without it. But it is kind of eye-opening to kind of step back and say, we're hurting a significant subset. And so the answer to that is, not to get rid of the drug, not to get rid of the procedure, but to figure out how we can address that subset that's getting hurt.
And so do you think that in addressing that, is it a matter of culture change and education for healthcare providers? But also, when I read your report, it made me think of the importance of advanced care planning and talking to patients and their families in advance, well in advance, years ahead of time, to ask what is meaningful to you, to make sure that they're really informed when they make decisions like this.
Yeah, but the thing you really want to, if you really want to inform them, you have to come clean and say, while this may benefit you and alleviate suffering and everything else, there's a small likelihood that this will also give you less care that's unrelated to your decision. Think of it almost like a potential side effect of it. And just like when we give someone, a medicine and say, well, there's a, 10% chance this antibiotic will give you diarrhea. Can you live with that? So I think one is really informing them. I don't think we can say, like, if you really think about it hard, these things won't happen to you. I think the real issue is on the clinical world, which is we have to make sure people understand that DNR does not mean do not treat.
No, I mean, I think that's the huge part of it. And so does that, and certainly on healthcare, the healthcare side, making sure that that is happening, people are being treated. Do you think that also means, and I'm again putting on my geriatric hat and my
Mm-hmm.
memory care hat, that also means really empowering advocates and family members to speak for their loved ones who might not
Right.
fully understand the situation and demand that care when
I
they're.
think you hit the nail on the head to just say, hey, just because my relative is DNR, does not mean, don't do the blood cultures, don't get a surgical consult, don't not round on them every day, you know. But again, I think of course that's going to help, but the real onus is on the medical world. But the real problem is not that. The real thing is that people in the medical world don't recognize this problem. I mean, I searched the literature to see if anyone else but us had connected all these dots. And there was one, article I saw that, kind of made it into the media, I think in the New York Post a few years ago. Aside from that, the medical community does not acknowledge that exists. And I don't think they're hiding it. The awareness is not there. And so if you went to a medical conference and brought that up, I don't think you'd get a lot of heads shaking. Oh, yes, we've heard about this and this is an issue. So you can't begin to correct it. Medical schools can't begin to drum it into residents and medical students' heads if no one is discussing it and acknowledging that's a problem. So an opportunity to speak to your audience and other audiences is really helpful. But I think we can't just be, just one person or one group of people bring it up. If we want to change, the medical community has to acknowledge that there is a perception problem that some people view DNR as do not treat, or some level do not treat.
So then what's next for E7 Health? What are you going to do with these powerful results? What is the next project for you?
I think in fact, we were just about to do another podcast on this, and which is really, I think in our first study, we talked about the problem, and I think focusing on what we just talked about, the solution is, I think, our next level, because it's all good and fine to point out a pattern that's very obvious. And again, I want to reiterate, I mean, every study that we looked at, and they all often referred to 5 other studies that corroborated what they were saying. So we just got exhausted after that. There was so many more that if somebody literally, I don't know what the true number is, but there may be 100 peer-reviewed articles on this, that if anyone really put it all together, it'd be very, very difficult to refute. But the question then becomes, okay, now that we've established it, let's be an advocate for a solution.
And so then now I'm going to ask you to put on your care hat. So as a critical care physician, and you've seen people survive and pass away in the ICU, what do you want people to know about CPR and DNR orders?
Well, I mean, let's talk about, let's say you have a terminal illness, and that CPR and do not resuscitate is unlikely to significantly change the course of your disease. People need to understand CPR is not without side effects. Often we break ribs when doing CPR to the level that the person is conscious. It's painful potentially. And then when we do, ACLS, we give certain drugs which have side effects. They're not without side effects. And then when you shock someone, I think people have seen that on TV, where the paddles are taken to someone's and the body sort of jumps up. And so these are not innocuous therapies. So clearly, if they're futile and they're not going to impact the patient's eventual outcome, and study after study has shown, like, if you do CPR and someone with a malignancy in the hospital, their chance of leaving the hospital is almost zero. I mean, so it can't CPR and ACLS and shock and intubation on some level can be viewed as futile care, where at best we're extending suffering and not extending life. So this is why it's so beneficial to people understand. And it goes to many other things, like the statistics, and maybe you're more familiar with this, that, people often spend 2/3 of their total life healthcare dollars within the last month or two of life. I think it goes to that because at a certain point, we provide all this very aggressive care that's futile, but we do it because the circumstances calls out for it. So I think that's the first thing to realize. It's easy to kind of walk away from this interview and say, "Oh, DNR is bad." No, it's really amazing, and it's you wouldn't do open heart surgery on somebody who wouldn't benefit from it, just because you can do it. So I think it's important to understand that too. I want to be balanced. And intubation, intubation has a lot of side effects. We can cause bearer trauma when we insert the ET tube. Being intubated requires often you be paralyzed or heavily sedated. And there are complications associated with that. So DNR is not the kind of care where we just want to throw at someone. And, we have the technology. We have the technology to keep someone, theoretically alive for weeks or months with absolutely no hope of them ever leaving the ICU or hospital. So I hope that puts it in perspective why DNR is so important. But the flip side is, just because it's important doesn't mean we can't address that subset of population that is hurting.
What advice do you have for patients or family members of patients who are admitted to the hospital with DNR? At least things for them to think about.
I mean, I think what I would probably, the advice that I didn't get to is, if people feel that they're being admitted to the hospital for a reason that doesn't connect to their original request to be a DNR. So let's say you have dementia and you want to be DNR and you get admitted because you have a ruptured appendix. Because one of the things that these studies pointed out is, let's say you have post-operative complications from a procedure that has nothing to do with the reason you were DNR. We see from these studies that people will not treat the natural post-operative complications of a procedure that has nothing to do with your DNR. So what I would say to, especially people who don't have the cognitive awareness, but certainly their families, to simply say, okay, my relative is DNR, but on this hospital stay, I want to revoke it because this person's here for a ruptured appendix that has nothing to do with whatever else. So, because this is the part that families are going to have a hard time controlling, especially post-procedure or what have you. Complications occur in a certain percentage of every, moderate surgeries. And you don't want to fall in the category where you had a natural complication of the surgery. Like, for example, sometimes when people, let's just say, appendicitis, they may have to go in a second time because, the wound dehisced or something like that, versus that may not be offered to someone who's DNR. And so I think from an advice point of view, just to realize that if you feel that something is going on, a hospitalization or a period within a hospitalization that has nothing to do with the DNR status, to either talk to your doctor or clinician and say, No matter what happens, I want to be treated post-operatively for all these complications. And then once everything's resolved, maybe go back to your DNR status.
Well, with that, I'd like to thank you for your time, Dr. Baktari, in explaining really important concepts for all of us, regardless of our cognitive function. And if you put out another study, we'd love to have you back on the show.
Oh, thank you so much.
Thank you for listening to Dementia Matters. Follow us on Apple Podcasts, Spotify, Google Podcasts, or wherever you get your podcasts to be notified about upcoming episodes. You can also listen to our show by asking your smart speaker to play the Dementia Matters podcast. And please rate us on your favorite podcast app. It helps other people find our show and lets us know how we're doing. Dementia Matters is brought to you by the Wisconsin Alzheimer's Disease Research Center. The Wisconsin Alzheimer's Disease Research Center combines academic, clinical, and research expertise from the University of Wisconsin School of Medicine and Public Health and the Geriatric Research, Education, and Clinical Center of the William S. Middleton Memorial Veterans Hospital in Madison, Wisconsin. It receives funding from private, university, state, and national sources, including a grant from the National Institutes of Health for Alzheimer's Disease Centers. This episode of Dementia Matters was produced by Rebecca Wazaleski and edited by Kaylin Rauerdink. Our musical jingle is Cases to Rest by Blue Dot Sessions. To learn more about the Wisconsin Alzheimer's Disease Research Center and Dementia Matters, check out our website at adrc.wisc.edu. That's adrc.wisc.edu. Follow us on Facebook at Wisconsin Alzheimer's Disease Research Center and find us on Twitter at Wisconsin ADRC. If you have any questions or comments, email us at dementiamatters@medicine.wisc.edu. Thanks for listening.